So, Katie.
Thank you. So my name is Katie Crawford. I'm with the American Cancer Society, and I love working with all of you immunization folks. So I just think up ways to weasel myself into a lot of your talk. So I know you're going to be like, why are we talking about colorectal cancer? Does anybody know what the FluFit program is, or does anybody implement it in their offices or any of their clinics? Okay, well, great opportunity. So colorectal cancer is the third most common cancer both in men and women in the United States, excluding skin cancer, and it's the second leading cause of cancer deaths nationwide. It's estimated that more than half of all of those cases could be prevented through screening. So we've got a big opportunity. And especially here in Indiana, there are some things that we can do to really make sure that our Hoosiers are screened. Okay, so this is going to be very brief. If you have questions, let me know. There are lots of resources out there. I brought a one-pager for everyone to look at. I also have one of my partners here, Andrea Radford. I'll let Andrea wave, and she is with the state and primary care team. She's on the same team as I am, and she works with federally qualified health centers. We also have hospital systems representatives that work with all of our hospitals throughout the state. So we have a lot of resources in terms of staff. So if this is something that you think might be, helpful or useful, or you'd like to learn more about, then we're happy to sit down and talk to you and really come up with a plan of action. All right, so risk factors for colorectal cancer. Age, most occur in people 50 and older, although we are seeing more often cases in younger folks, 45 and below. A diet of high red, or a diet in high in red and processed meats and low in fruits and vegetables. Low physical activity, obesity, alcohol use, and then type 2 diabetes, as well as a family history. So our screening guidelines, we recently put out new screening guidelines because we are seeing so many younger people being diagnosed with colorectal cancer. And again, this is a very deadly disease and highly preventable. So at age 45, we recommend that both men and women at average risk begin regular screening, either with a sensitive stool-based test or with a visual exam, like a colonoscopy. People who are in good health and with a fine life expectancy of more than 10 years should continue screening up through the age of 75. So many colorectal cancers can be prevented just through our regular screening methods. So why is it important to screen? Because if you find a polyp, if you can find that polyp before it becomes cancer, then you hopefully have decreased an individual's risk and also saved an additional individual from having that cancer diagnosis. And also when colorectal cancer is found early, it's much more treatable before it's spread to other areas. So how is colorectal cancer screening done? So most people know about colonoscopies, obviously. How many of you offer a stool-based test in your office? Okay, so there are other options as beyond just a colonoscopy. So colonoscopies are great. People, you're done for 10 years. They can remove those polyps. But there are other options. So, and these are oftentimes options that fit better for folks that perhaps are a little bit more adverse to having a colonoscopy. Perhaps they don't feel that they can take the time off from work to do that. Perhaps they feel like, the prep is too invasive, and a, at-home test is obviously a lot more private. So you can do the visual exam, your colonoscopy, or a stool-based test. So these are tests that mainly find cancer. So the FIT is the fecal immunochemical test. You've got an FOBT, which is a guaiac-based fecal occult blood test, or a stool DNA test. So your Cologuards, and I'm sure you guys have seen the ads for those. So the stool-based test, a FIT test and an FOBT, you need to do every year. A stool-based DNA test is every 3 years. And all of these tests look for hidden blood or all of these tests the stool for hidden blood and other changes that may be a sign of cancer. They're less invasive, they're easier to do, they're a lot less expensive. They are less likely to find polyps, but if they're, which is why they're done annually. So if there is a FOBT or a FIT that comes back positive, then they are referred for a colonoscopy at that point. So nationally, over 30% of age-eligible individuals are not receiving their recommended colorectal screening. Here so the U.S. screening rate is 67.7%, which is much better than it was several years ago. Has anybody heard of the 80% by 2018 campaign initiative? So this was a pretty big initiative, and it was led by the American Cancer Society, along with partners at the NCCRT, which is the National Colorectal Roundtable. And the idea was really to create a big buzz around colorectal screening, because it's super fashionable. It's not something that people like to talk about. And it really helped. We were able to see these screening efforts throughout the country. People signed on to talk about getting screened, and they sort of signed a pledge to really put a lot of effort and intent behind talking with their patients, as well as employers, reminding their employee, hey, you just turned 50, it's time for your colorectal screening, and by the way, you have insurance and it's covered. But here in Indiana, our screening rate is 64.6%. And you can see quite a bit of difference between the males and females there. So we've got some room to go. So this is some information around screening rates in our FQHCs. So we are only at 39.1% up-to-date screening rates in those FQHCs. And they see a lot of patients, so there's a lot of opportunity there, especially for this program. So in talking about the Flu-Fit program, this is an opportunity where a patient comes in for a flu shot, and at that point, you offer them a FIT test as well. So it's very simple, it's easy. You talk to them about how they take the FIT test, you send them home, and hopefully they either return it to the office or then they have follow-up instructions to send it off to the lab at that point. So there are a couple of steps. So annual flu shot visits are a great opportunity to reach them. They're coming in yearly. This is a test that you need yearly. The office staff checks eligibility and educates the patient while they're waiting. The patient completes the test at home and then returns it. The results are then communicated with the patient by the office staff, and patients with positive results can easily be referred to or for a colonoscopy. So why try it? Because it's annual. These are oftentimes people that are health conscious and generally accept a stool test if they know that it's needed. And the studies have shown that the Flu-Fit leads to higher colorectal screening rates in a variety of clinical settings. So there are a lot of sort of steps into forming this plan, and I actually have a one-pager for all of you guys, and I'll make sure that you guys all get that. But it goes through the steps. So you want to form a team. You're going to train the team on how to make a strong case for the FIT testing. You're going to design a workflow, and we'll come in and we'll help you with all of this. We've got lots of great charts and graphs and information, talking points for each of your staff. But this is something we'd be happy to help with. You're going to choose times and locations for the program. So, it may not be something that you do year-round. You may say in the month of September, we're going to do this Flu-Fit campaign, and we're going to make sure that we have enough FIT tests on hand and hand them out to everyone that's eligible. You're going to look up your patient's eligibility. So, looking at your patient load, looking at, today's Wednesday, who's coming in Thursday. Do they need a colorectal, screening? Okay, let's go ahead and talk to them about that. Develop that follow-up plan, so making sure that I'm sure with most of your patients, being able to have some sort of reminder system in place or navigation, so calling the patient, hey, we sent you home with a FIT test a week ago, 2 weeks ago, please don't forget to bring that back or send it in. Just making sure that you have some sort of touch point with them, that they don't slip through the process there. So implementing your plan and then tracking your data. FluFit.org is a great website to consult. They have all of these one-pagers, there's action guides, there's posters for your office, there's just a plethora of materials and information on that. So that was really quick. But this is the FluFit.org, and it's part of the NCCRT, which if you don't know what the National Colorectal Roundtable is, I highly recommend you just nccct.org. It's a great website. It has a ton of information. They try to make it as easy as possible for you to offer colorectal screenings and to really get your screening rates up. So, I can't tell you the exact numbers, but I want to say this is something that we can do very short term. If we screen folks for colorectal cancer, we can prevent something like 230,000 cases of colorectal cancer by 2030. So in 10 short years, we could prevent a lot of cases of cancer. So does anybody have any questions? Yeah.
Can you go back to the different type of tests?
Sure.
Because that's what I'm confused about. I thought all of them just tested for blood, but they also test for DNA changes?
So the stool DNA, we can look this up and get you more information. Okay. It's the Cologuard. It's just a different type that looks at the DNA of the stool. But as far as I understand, yes, they're all looking at blood. Andrea, do you know any more information on the differences there?
No, but I'm making enough.
Okay, thank you. I know that FIT tests, in terms of the folks that I have talked to, FIT tests seem to be the preferred test that a lot of health centers use. I think that they're maybe easier to understand and then administer to their patients.
What's the second one, GFOBT?
That is here, let's go back one more. That's going to be your guaiac-based fecal occult blood test, which is just a different type of stool DNA test. I think that the FIT test is, like I said, just a little bit more refined, it's a little easier to use, the instructions are a little bit more clear. So, but it makes, a lot of times the folks that are coming in to get their flu shot oftentimes are the right population that we need to target. My parents both have insurance and they're pretty health conscious and they were pretty reluctant. My mom was 5 years, past getting her colonoscopy. So a colonoscopy was the right choice for her, but a lot of times the stool-based DNA test or the stool-based tests are a little bit less invasive, and like I said, they're just a little easier for folks to do. Now it is something you have to do on an annual basis, so that's why it's nice to couple it with the flu shot, because that is something folks are coming in to get annually as well.
Is this the first time the initiative has been launched here in Indiana?
It's something that we've talked about for a long time. I've never had an opportunity like this to sort of talk to a whole bunch of folks that might be able to initiate it. But I know several of our FQHCs do utilize the FluFit program, and it really is just, it was just an idea that I think came out of a journal, a medical journal, 10 years ago or so. They said, hey, what if we tried this approach? What if we talk to everybody as they get their flu shot for this? So it's not, it's a pretty simple idea that has had a lot of success throughout the country.
What's the cost for the tests?
Ooh, FIT tests are pretty inexpensive. I couldn't tell you exactly what the cost is, but I want to say it's like $20. I know that in Illinois, they had, I want to say, gosh, it was like 2/3 of all of their health departments decided to tackle this initiative, and they just bought the kits outright and then just passed them out. And I think that it was just an easier lift for them. So if that's something that, if you are a health department and you're interested in that, I'm happy. We help them with that program. So we have a lot of materials created that they utilize with their patients, and I'd be happy to help you get connected to sort of see, how they went about that in the health department setting.
It says $20 or less.
There you go, $20 or less.
So does that cover the cost of setting it in and having the lab results come back?
I don't know about that part, but we can find out, Andrea.
I know that the FIT is cheaper than the Cologuard, so for patients that do not have insurance, they will get the FIT test.
Cologuard is a little, and I am not endorsing one test over the other. It's my understanding that the Cologuard, the company itself sort of takes care of that follow-up effort. So like if a patient gets a Cologuard test, then Cologuard themselves or whoever manufactures it, they're doing that navigation. They are calling it and, really sort of pestering that patient until they receive it.
So typically with the Cologuard, there's an order that is placed, and then the patient will receive the Cologuard in the mail,
Right.
and then they're to send it back. If they don't, then Exact Science will contact them, and really kind of harass them to get them to send it back, or for the patient to say, leave me alone, don't call me back. With the FIT, that's not the case. So the follow-up is done by the office staff, phone or text or whatever your office has already in place. And then with the FIT, you actually give it to the patient in the clinic rather than having something in the mail. And then, as Katie said, with the FIT, the patient can either bring it back to the office or they can mail it back. Whereas the Cologuard, is always going to have to be mailed back.
I was noticing on the Cologuard commercial, because it's on all the
Oh,
time.
yeah.
And what does it say, 13% of false positives come back? That would be frightening. If you-
Yeah, that is something to consider. But a lot of those people are people that will not go and get a colonoscopy. So their cancers would never without it.
What did you say the criteria is for using those?
So these folks have to be of average risk. So if you have somebody that, has a family history or, has some sort of hereditary condition that it makes them more prone to cancers or colorectal cancer in particular, this would not be a good option for them. Most often those folks probably are receiving their colonoscopies. But this is somebody that's just going to be an average risk. Any other questions? Well, thank you guys so much for letting me come and talk to you about colorectal screenings. And thank you for giving me some time today. I do have some one-pagers. I'll make sure that those are available over there. And then if you have questions, feel free to connect with Andrea and I. Thank you.